Dear ladies and gentlemen, a very warm welcome to our Leica 2021 Online Neurosurgical Visualization Summit. For those who've joined us previously, welcome back. My name is Jennifer Sarah Boone, and it is my great pleasure to be your host for this week. We hope you will enjoy our clinical symposium on the benefits of Fluorescein and ICG, and we are very happy that Professor Marco Cenzato took the time today to lead us through the presentation. Before we start, just a couple of tips for you to make it the best possible experience. A little bit of housekeeping, so to say. First up, your questions are more than welcome. Please use the dedicated tool on the right side of your screen to submit your questions. You are very welcome to submit them during the presentation, and then we will address them at the end. Then on the left side, you can see that there are resources available linked to the topic of this symposium. We recommend to bookmark the links, and then you can browse through the resources after the session. In case you have a VPN that you're using, we would recommend to disconnect it, as well as recommending to close all unnecessary tabs and applications so that you can enjoy the high quality images and videos that our speakers will be showing you in the best possible quality. And last, if you have any issues, press F5 and then you can refresh, and then hopefully the issues will be gone. Another important note is that off-label uses of products may be discussed. Please check regulatory affairs for cleared indication of use in your region. In addition, please note that the statements of the healthcare professional as part of this symposium reflect only his opinion and personal experience. They do not necessarily reflect the opinion of any institution with whom he is affiliated. But with that, I am now very happy to introduce Professor Marco Cenzato, who is the head of the Neurosurgery department of the Niguarda Hospital in Milan, Italy. He's specialized in vascular neurosurgery and particularly in the treatment of arteriovenous malformations, difficult word for me, cavernous angiomas of the brainstem, and complex intracranial aneurysms. He's the past president of the Italian Neurosurgery Society. Please take it away, Professor Cenzato.
Hello, nice. I'm very happy to be invited here, and it's a big pleasure for me to present my experience on the use of fluorescein and ICG and video angiography in vascular neurosurgery. So should I screen share now?
Yes.
This is, I hope you can see it. Is it working?
At the moment, we can see the slide 5.
Yeah.
Yeah, we see your screen.
You should see my screen. Do you see it? Okay.
Yes, perfect.
Thank you very much for inviting me in this speech, and it's a very big pleasure for me to explain my experience and to talk about this interesting topic for me. The use of video angiography really changed the experience of a vascular neurosurgeon, because having an intraoperative view is something that gives us much more information than we used to have. First, I have to present my disclosure. I'm a consultant for Leica Microsystems, so this is a topic that we already have discussed with Leica. We will present some off-label use of the indocyanine green and FL560. And as they said before, is not always usable in all the countries, but this is a very interesting way of seeing the vascular neurosurgery, vascular pathology during neurosurgery. So I think it will be used in the future, although is not now permitted in some countries. So the sodium fluorescein is not new. It's something that came out in 1950 from the ophthalmologic use to study the ocular fundus. And it has been transferred to neurosurgery in 1968 by Fendel, who performed an angiography during a craniotomy. It was described in 1994 for the first time in the use in microsurgery of MCA aneurysm, and it has been used putting a filter overimposing it on the microscopic view of the neurosurgeon. This, of course, was an artisanal way of doing it, but this is the first publication that presented it in 1994. And although sodium fluorescein is much older than the indocyanine green, the indocyanine green came later, much later, but now it is much more common in the neurosurgical use. And this is due to some elements that we will see later. And now every vascular neurosurgeon knows perfectly indocyanine green, and much less knows the use of sodium fluorescein. But I think that this is interesting to use. The indocyanine green, the FL800, has been discovered by Andreas Rabe, and he is, everybody knows him. He is a famous neurosurgeon that works in Switzerland, in Bern. And he found it after he told me that he saw it in a congress where they showed the use of it in ophthalmology, and he thought he could transfer this technology also in neurosurgery. So he told me that he went to talk with Tetzler, and they together start to use this in neurosurgery. The first publication was in 2003, and on a series of 12 aneurysm and FDA and dural fistula they presented the use of this in vascular neurosurgery, and this opened the use of indocyanine green in all neurosurgery, and now all the microscope has the use of indocyanine green in neurosurgery. And since then, indocyanine green became a very wide had a very wide application in all the neurosurgical fields. AVM, aneurysm, and neuro-oncology, and so on. But sodium fluorescein had been presented as a low cost. This is a publication in 2018 that presented the use of video angiography with sodium fluorescein in aneurysm malformation. And this is a low cost. It presents a fine details of AVM. And the most important advantage of this is that you can see it directly in the microscope. While the use of Indochine green requires the use of the to look at to another screen, not looking in the microscope, but you'd have to look in another direction and look at on the screen. This is something that you can see directly in the microscope on a real-time overimposing what you are looking at. So this is for me a great advantage. And also, it has been presented in this publication of 2017 on aneurysm surgery, which is it presented the advantage of this as a great value in cases of microsurgery. Now we know that we are moving to a less invasive surgery, retractor-less, so we have to keep the exposition while we are there. So without retractor, it's very difficult to expose something and look somewhere else. So the advantage of this is that you can observe where you are and while you are working on your surgical field. Fluorescein has, as Indochine green, and with like all the other angiography, it has 3 phases: arterial, capillary, and venous phase. And so all the characteristic of the vascular pathology can alter this and can show different times. And this is what we want to know during surgery, because we want to know what comes first and what comes later. And this is the use of video angiography during surgery. So, as said, Indochine green requires a separate infrared camera attached to the operating microscope and show it on a different screen and not in a real field that you look at where you are looking in the microscope. Sorry. While sodium fluorescein requires only a filter and can be visualized directly in the microscope and during your surgery directly. Fluorescein require a stimulating filter that has to change the wavelength of the light, so it can shift the light toward a restrict limit of wavelength, and then a filter that filter the wavelength in a specific range. The advantage of the sodium fluorescein is that is an inert dye. There are no reported acute toxicity. It can have some allergic reaction, and the advantage is that the cost is very cheap. The cost of the sodium fluorescein is 12 euros each vial, so it's very cheap. The disadvantage is that remain in the blood for at least an hour. So this is the main difference between ICG and sodium fluorescein. With the ICG, you can have a second and third injection in a short time, while sodium fluorescein has a longer a long time, remain for a long time within the bloodstream. So this is something that prevents the repetition in a short time. You have to wait at least 1 hour to repeat it. But as said, indocyanine green is eliminated and it has a half-life of 3-4 minutes, so you can repeat it very soon. It has some also indocyanine green has some hypersensitivity to iodine, and so you cannot use in patient with hyperthyroidism or with problem of the thyroid. But another difference is that is much more expensive. As you see here, the cost is 240 euros each vial, so 20 times the cost of the sodium fluorescein. So after this introduction, I will present the use of it in some specific field and where I found it very advantageous, very interesting, especially in the use of AVM, and then we will present the bypass, and then we will present aneurysm also. So these are videos that want to show you the difference and the advantage of the use of one or the other dye to see intraoperatively. So this was a patient with left frontomesial AVM. You see here, this is the MRI, and you can see the AVM, and this is the angiogram. It was a small one, single feeder, single vein coming from the surface. The AVM is behind the vein, so we decided to take this AVM from a contralateral access to expose the AVM and to avoid the dominant hemisphere because it was on the left frontal lobe, and also this to have a better control of the feeder. So this was, I hope you can see the movie. This was the AVM exposed. On the top you have the falx. This is the falx, and then you can see the draining vein, and below it there is the AVM. But what I want to show you here is the use of intraoperative sodium fluorescein, and to show you how you can see exactly what you are interested to see. So the timing, the feeder that comes, and the vein coming after, and all the short small vessel around the AVM. But as you see here, this is exactly what you see through the microscope. So you can see in your surgical field this image showing you directly the contrast within the vessels. And this is the post-operative angiogram. We took out the AVM. This was a clip on the feeder, and this is the post-operative angiogram without any residual. This is another image. This is another AVM, and I want to show you how to this is what you see with the ICG on a screen, and you have to look on another screen to show you. This is another AVM. You have to look on another screen to understand what you are looking. And as you can see here, the main problem with ICG is that you don't see anything surround the surround of the AVM. So you have to interpret this is one vessel, then look back on your surgical field, and this is that, and so you have to understand shifting from one monitor to the real time, the real video, and this is the same AVM with another way of looking at it with the intraoperative echo Doppler, and this is a very nice way of looking at the AVMs also, because it gives also real-time view in the surgical field. But this is what you see with the FL560. And as you see here, this is what you see in your surgical field. You can recognize directly in the same AVM you saw it with the ICG. You can see here how the definition is much more easy to understand, and this is exactly what you see on your surgical field. And you can see here the main feeder, how these other vessels come later, and the surgical vein, the draining vein, how is injected early and then diminish his contrast. So you can see, comparing the two video, the different information you can have and comparing them together, you can see what's the difference seeing the real field and seeing the other ICG information on another different screen. You see the information is almost the same. You can understand what you are seeing, what you are looking at, which are the vessel, but one is on a dark background and is not the same like looking in the surgical field directly. And always you have to do a transposition and try to understand which field, which vessel is on a screen, and then look back on the surgical field and recognize it and try to find it. Here you can see directly what you have on your surgical field. This is another small AVM and a temporal lobe, a small AVM that was removed. Also here you can compare the two way of looking at it. This on the left you have with the Fluorescein, and on the right you have it with the Indochine green, and you can see that the two images are much different. They you can see also here the detail, how all the small vessel can be seen directly on the surgical field, and you can understand how the washout of the vein is earlier and faster with the Indochine green, and while earlier and faster with the sodium Fluorescein, while the small vessel, arterial vessel, remain perfused later with the one we are not involved in the AVM. One of the main advantages is also that you can, once you have removed the AVM, you can check it. You can check the vessel. You can see here that while on the right side you have a dark and black hole, you can see here your surgical field perfectly. You can see how the surrounding parenchyma is perfused, and all the small vessels that remain perfused. So as I told you, it takes almost 1 hour to clean the blood from the fluorescein, and this can be a problem if you want to check it again as soon as the first one. So this is something that it's a problem because as you see also here, fluorescein remain on the field, and it remains, you see here, there are much more images on the surface where we cut the surface of the brain, and so on the cutting margin, you can see that some fluorescein remain from the previous injection. So this is something you have to keep in mind. But one of the advantages is that you can work also looking at the same screen and working below under the infrared light to see the light, fluorescent light, to see directly and work directly in your surgical field in the same way. This is another AVM, another big AVM that also here we came from the this is another one similar to the other but bigger, and also here we came from the contralateral field. This is the large AVM, frontal AVM, and also here you can have the same information. This is the falx, so the draining vein, the corpus callosum, and the left pericallosal artery. And also see here, this will show you the advantage of having the fluorescein information directly in the surgical field, where you can understand the feeders and the draining vein on directly in your surgical field. You see here, right pericallosal artery, left pericallosal artery, falx, and in the middle you have the draining vein. So in the AVM, the advantage of this is that it's easier to identify feeding vessel directly in the surgical field. You don't need to look elsewhere and then try to identify the vessel you are interested in. You have a better visualization of the parenchymogram, and the disadvantage is that you have less contrast between vessels probably, and that multiple evaluation can be compromised by the long permanence of the dye on the surgical field. But if you keep in mind that taking out an AVM requires always more than 1 hour, and if you do it in the beginning and then you do it at the end of the surgical resection, this is a very useful and interesting way of looking at it. Also in bypass, it's very interesting. This is a bypass in a Moya patient where we did the STA, MCA in this patient. And also here is very useful to explore and to see, to check the STA. This is the STA exposed on the parietal surface under the skin. And you can see here also how the fluorescein will show you the function and the functionality of the artery during the direct vision of the surgical field. This is the STA before taking out it, and this is the bypass done. And you see here the bypass. This is the STA that is already sutured on the recipient vessel. Is M3 in a Moya patient, and you can see here how to check if everything works. Endogenous fluorescence is very effective and shows you how the bypass works and how the recipient vessel are perfused, and also you can see the detail of the parenchymogram, how all the small vessels over the surface of the brain are perfused by this image. This is the post-operative control, and also here, this is how the bypass works. All the on the right, you can see all the vessels perfused by this STA MCA bypass. Also, this is another bypass with radial artery, so a long bypass, a high flow bypass in a patient with an aneurysm that has been excluded by endovascular mean after the bypass. And you see here that this is also here before and after. And after, you see here also how the injection of Fluorescein shows how the bypass perfuse the brain, and how the recipient vessel is perfectly injected. As you see here, the radial artery has a thicker wall, so the transparency and the image of the contrast through the wall of the thicker artery is less evident than before. But this is the goal here, is to see if the recipient vessel was functioning. And also here, this is the proximal suture. And also here you see that the radial artery is much less injected than the smaller vessel in the brain. This is the distal in the brain part of the radial artery. So in bypass, you have a very good visualization of the vessel, very good visualization of tissue perfusion. When you use thick vessel like the radial artery, maybe the contrast is a little less evident, but you have other way to understand it, to see if we also use Doppler, and so we have other way to understand if the bypass works. But what is important is that you can have a very good visualization of the brain vessel, which are the one you are interested in. And finally, the use of fluorescence in aneurysm is another important thing. This is a small aneurysm of the MCA. You see here, and this is before, and then this is after a clipping. And you see here that after clipping, the contrast is, this is the same image under the with fluorescent, and you can see here that when fluorescent come, the aneurysm is completely excluded from the contrast. And What is interesting mainly in aneurysm surgery is that you can see also the perforators. One of the problems of the surgery of the aneurysm is that you cannot see sometimes the perforators, and one of the risks with the clipping of the aneurysm is that you grab a perforator that you probably you are not allowed aware of it. The advantage of this is that this way of direct looking in the surgical field is that you can see directly the perforators and if they are perfused. And this is something that you can miss in with the ICG, because with the ICG you have to look at another screen, and if a perforator is not perfused, it is dark, it's black as the rest of the background, so you cannot recognize it. Here you can see, maybe this video can go again, you can see here that the perforators below the aneurysm are exposed, and here they are. You can see them here, all the small vessels are perfused directly, and so you can check exactly if the perforators are functioning and not occluded by the clip. This is, for me, one of the great advantages of the use of the Fluorescein in aneurysm surgery. Also here you can see the difference in this is before exposing it. This is the aneurysm before clipping. You see here how you can see the aneurysm and before clipping and after clipping. So in conclusion, also in aneurysm, you have a very good contrast. Occluded aneurysm are clearly evident, and you can look for the perforator and manage them directly in the surgical field. The problem is this, as I told you, aneurysm surgery is much quicker and faster than AVM surgery or bypass surgery. So if you have to repeat it, it is something that is less useful, because you don't have a clear picture, because as I told you, fluorescein remain in the blood for at least 1 hour. So it's one shot. You have to do it after surgery, after clipping the aneurysm, and to check for perforators, or to check if the aneurysm is excluded. But I find it very interesting in vascular surgery. But another question, another topic is that one do not exclude the other. So if you start with the fluorescein and you want to show the detail, you want to show the vessels, and you want to show the perforators, and maybe you need to repeat it, you can do it with the ICG. One do not exclude the other, but this is a technique that can be useful, and because all the microscope already have ICG, you can use this in conjunction with the ICG, or if it's enough for you, instead of the ICG, but there is no problem of using one and the other. Also here for thick vessels like carotid, probably the image is less evident than with ICG. So in conclusion, this is another paper that says that is 2 years ago, published 2 years ago. The advantage of video angiography with fluorescein, sodium fluorescein, is that you have the three-dimensional visualization directly in the field, and this is one of the main advantages of looking directly in the field with the 3D perception as you normally have in your surgical field, and the high detail, the very defined details of all the small vessel, and it allows you also a real-time surgical manipulation, because you are there and looking what you are doing, so you can expose with a dissector or with the aspirator, you can expose something and look at it, which is much more difficult looking on another screen. And the only disadvantage is that probably thick-walled vessels are less evident, and that the dye remain in the vessel for a longer time than with the ICG. And also as I say, you can manipulate the vessel, and more important, is much more cheaper than the ICG. Thank you. I hope that you could understand. So I end my screen share, and Jennifer Boone will take the control of the presentation. Thank you for me. Thank you for having invited me, and for letting me explain my point of view on this interesting topic. Thank you.
Well, thank you so much, Professor Cenzato, for taking the time, for being here, and for leading us through this fantastic presentation. Thank you very much. We'll be heading to our questions in just a moment. But for you, dear audience, let's take a look at the supporting Leica technologies for vascular neurosurgery. Those are the RVO digital augmented reality microscope, the M530OHX surgical microscope, and the FL560 and FL800 fluorescence modules. If you want to learn more about the technologies, please feel free to reach out and request your own private session. You can see on the slide there are several different options, so just choose what is the right option for you, and don't hesitate to reach out. And now I'm very happy that we will come to your questions. Thank you very much for submitting them, and then let's take a look what you would like to know. So the first question, Professor Cenzato, is, dear Professor, would you say that the FL560 is a good complementary diagnostic tool of the FL800?
Yes, this is what I said. And in my opinion, this is something that is precious to have in the surgical field, together with the ICG, with the FL800. Because, as I told you, one do not prevent the use of the other one. So this is something that we have in a junction, and it's a very nice image to see. It's a very it's also to look directly in the surgical field, and having it in 3D is a very nice view, which is very interesting to have. So I think it's something that is not, you have to substitute the ICG, but it's something, as you say, it's a good complementary diagnostic tool and surgical tool also, not diagnostic, but a surgical tool to understand what you have done and what you are doing.
Thank you very much. Then let us take a look at the next question. So next up, our viewers would like to know, dear Professor, do you use the FLNA to see tumor vascularization?
Well, this is a difficult question because sodium fluorescein was done mainly on surgery for tumors, and as you know, this is something that goes through the blood-brain barrier, so the use in tumor is something that it has to be, you have to be aware that you are not looking at the tumor, but you are looking at the brain barrier damage. So if you take out a tumor using this sodium fluorescein, the risk is that you take out too much brain, because if you, one of the problems you have in tumor surgery is that when you work in a part, I remember that once I was taking out a glioma, and the first experience of this contrast dye, we worked on the boundary of the tumor, and then the impression is we resected this. This is not tumor and this is brain. This is tumor and this is brain. Then we work in another part of the field. Then we came back and we said, oh, there is still some tumor that we left. But this was not tumor. This was blood of the brain that where we work. So the resected the part, you don't have to go back, because otherwise you still go, the risk is that you go further and further following something which is not the tumor. The problem is, depend on your question is tumor vascularization. Of course, tumor depends on what your tumor you are speaking about, because glioma has a very disruption of the blood-brain barrier, so you don't see only the vascularization. You can have a first shot of the vascularization, and then the dye will go in the tumor. So when we have to work with the tumor, we don't, as you know, you have to give the fluorescein in advance when you are at least 1 hour, or when you are opening the patient during anesthesia induction, to have the parenchyma of the tissue of the tumor contrasted. We normally do it for tumor. I don't have experience if you want to see only the vascularization of the tumor, but I don't know which information this can be, why this information can be helpful. The goal of the resection of the tumor is different. You don't need to have exactly the vascularization of the tumor. Probably it can be more useful to check the tumor itself rather than a single shot during tumor removal. I hope this was the question.
Well, thank you so much. Then let us take a look at the next question. How safe is sodium fluorescein when injected intraeffectly?
Apparently, is not is the one you use when you have the risk of fistula. This is the same that the ENT used to check fistula, so it doesn't seem to be dangerous. There is no. The only problem is you can have allergic reaction, but it seems to be very safe. It has been used since 30 years from the ophthalmologist and from the ENT to check fistula, CFF fistula. So it doesn't seem to be, for what I know and for what is well known, is not something more risky than. But also, you don't inject it intrathecally, as you see here. Probably there are some as you see in some of the videos, some dye will come out with the blood in the surface of the brain, but then you can wash it. But it's not something you can. It's dangerous in the CFS. Last question is, do you use augmented reality? Well, I didn't use it. I saw it, I tested it, but it's something that augmented reality with Glow 800 is something that you have to overimpose on your optic view. And sometimes this is hard to match exactly. You have to overimpose a digital image on an optical image, and this is not easy. For sure, this will be very interesting when we will go all digital, as with the exoscope or with the other way of looking at it, but with the probably with the exoscope, overimposing a digital image on another digital image will be much easier than overimposing an optical one with the digital one, because there is a little lag, there is something that is disturbing the view. The advantage of this is that you have almost the same effect, but in real life, in an optical image coming that you see directly in your eyepieces of the microscope.
Thank you so much. Then let us take a look at the next question. So can we have the next question on the screen? Yes. Dear Professor, how does the amount of fluorescein given to the patient affect the visualization and the staining of the vessels?
Well, it's there are there is I showed you before. There is a specific amount you have to give. To be honest, once there was a patient, an anesthesiologist that did the mistake, and we gave a much more higher amount of dye without any reaction from the patient, but this gave us a very bright view of the whole brain dura and all the vessels. So of course, if you if you give too much dye, the image will be too bright, and the contrast will be everywhere. So you have to do to give it in the proper amount and let it wash and wait for 1 hour to go out. But as I told you, is not toxic, so you can give a lot of also higher dose without any adverse reaction unless the patient is allergic to it.
Okay, thank you very much. Then let's take one last question. Can we see the next question? What does the future of neurovascular surgery look like according to you in terms of approaches, technologies, and biomarkers?
Neurovascular surgery is something that is now in danger, as you know. All the many of the vascular pathology has been taken out by the endovascular, and this is a good thing. I agree that aneurysm has to be as a first choice by endovascular, because the results are good, and there is no way to insist on surgery when you have to deal with normal aneurysm. Of course, vascular surgery will remain for complex aneurysm, for bypass, for AVM. At the moment, there is no alternative. AVM are mainly surgical unless they are small, that can be treated by radiosurgery, but I strongly disagree with the way of treating AVM by endovascular, because we already have a very bad results with a very low number of exclusion of the AVM. So AVM will remain for at least until a new invention will come out, remain for sure surgical for a long time. Bypasses are, of course, neurosurgical. Of course, the use of flow diverter changed the approach also to giant aneurysm and to large and complex aneurysm. But cavernomas are also something that we are looking for. If a drug will change the history of cavernoma, probably also AVM, we will find a marker, and we will find something that will change also the approach from a pharmacological point of view. From my point of view, I think that microscope will shift to exoscope because the advantage of using a digital image is higher, much higher than the optical image. The quality is for sure something that is important, and for the moment there is some work to do on the digital image and on the quality of the digital image, but I think that this will be the future. And because with the working in a digital field, you can overimpose whatever you want, and you can have navigation and geography and everything overimposed in what you see on the surgical field with a digital image and digital visualization.
Well, thank you so much, Professor Cenzato, for your work, for your passion, for your time today. Thank you very much, dear audience, for your participation, for your input, and of course, also for your time. Our Leica 2021 Online Neurosurgical Visualization Summit will continue until Saturday. So let's take a look at the schedule. You can see there are a lot more sessions to come. So please feel free to register for the upcoming sessions to gain more fantastic insight. So thanks again to everyone. I hope to see you in one of the upcoming sessions, and enjoy the rest of the day. Thank you very much.
Thank you very much, and hello to everybody. Thank you very much, and see you again.